Hello, my name is John Marcille. I'm the editor of Managed Care magazine. And with me today is Sonja Sherritze, the editor of P&T magazine. Today we're talking with Dr. David Nash, who is professor of health policy at Thomas Jefferson University and is the founding dean of the Jefferson School of Population Health. So, David, how are you?
Great, thanks.
It's been about 3 years since we had one of these interviews, and I looked forward to this for several months. In our previous interview, you mentioned that the pieces of the Affordable Care Act that were not getting attention at that time, such as the CMS Innovation Center and the Patient-Centered Outcomes Research Institute, PCORI, were really the exciting pieces of the legislation. So they are in place today. How do you feel about how they're operating and how they could be improved?
So here we are, nearly 3 years after at least enaction of the bill, and what do we have to show for the last 3 years of effort? When I think about the Center for Medicare and Medicaid Innovation, I think they've made tremendous progress in the last 3 years. Dr. Rick Gilfillan was the inaugural director, no longer at CMS, but CMMI, as it's come to be called, really is largely responsible for the nationwide effort at implementing bundled payments. We've got probably 30 million Americans in some type of bundled payment experiment across the whole country, largely for procedures, hips, knees, open heart surgery, and so on. So that's a real important accomplishment from the Innovation Center perspective. I think it's too early to tell the progress of the Patient-Centered Outcomes Research Institute, or PCORI. Certainly they got a lot of funding support. They moved into beautiful new offices. They have all full-time staff now recruited up and running. They brought people from all over the country, from Kaiser, from Aetna, and elsewhere. They have a national advisory board. But it's way too early to tell the impact of the grant-giving mechanism, because they're just giving out these awards. It'll be 2 to 5 years before we have any feedback as to what the work that was accomplished under the grant award system. So summary, I think CMMI has done a great job, largely with bundled payment experiments. PCORI, probably too early to tell.
Bill Seiberg, the director of PCORI, had said that it was intended to be comparable to NICE, the Patient Outcomes Institute in the UK. Do you think that will eventually be a fair comparison? Obviously, it's not right now.
So, as our viewers know, there is no NICE yet in the United States, the National Institutes for Clinical Effectiveness. Basically, a wonderful British idea for making sure that if we're going to put a drug or a device on a national formulary, that it's got a good cost-benefit and cost-effectiveness ratio. Nothing like that exists in the United States. FDA, basically safety and efficacy, and that's where the conversation stops. So, current state of events, no way will PCORI become NICE.
Okay.
It might become NICE light,
okay,
but as we know from the ACA passage, the Republican Party insisted that PCORI's work not be tied to any aspect of reimbursement. So it's a statutory prohibition against linking PCORI to any aspect of payment, most especially for pharmaceuticals. So here's where I think we're headed. I think we will see the FDA asking more questions about, do we really need that 10th beta blocker and that 14th ACE inhibitor?
Right.
Good questions that they ought to ask. But it'll be a long time before we're even ready for NICE light, as I like to call it. If there's going to be a NICE light, PCORI will probably fill part of that void. But we're a ways away from anything like that currently.
Okay.
Do you see the possibility of a parallel institution growing up, perhaps not involved in government, that might take on that function?
I believe that we can't continue to put every drug willy-nilly on every formulary. And that's a big challenge both at the hospital level, at the managed care insurance company level. So we're going to need some better information about the economic consequences of these products. With regard to who will sort of generate that information and who will be responsible for its implementation, at this moment, I think it's a toss-up. I would not, personally speaking, I would not want to see yet another federal agency engaged in this activity. I think the work of AMCP, the Academy of Managed Care Pharmacy, the dossier system, in a way standardizing the approach to how we make a formulary decision, and the work of lots of other folks, that's a step in the right direction. But I would not want to see a new federal agency of any type being involved even further in the conversation about which drug gets approved, which drug is on which formulary.
Let's stick with costs and procedures and treatments for a moment. When we talked 3 years ago, you used the phrase, and I thought this was pretty good, no outcome, no income. And talk to me about how you feel that we made or have not made progress toward this goal, and expand, of course, on what no outcome, no income means.
Great. So no outcome, no income, that's been our mantra since March of 2010. And what does that really mean? Well, what we hope it's evolved into, and maybe we should have copyrighted that no outcome, no income. What we think it means is something along the following lines. You know, we've got $750 billion, give or take, of waste annually in the system. Waste of resources, waste of overutilization, waste of inappropriate testing, waste of using the wrong drug. We're talking hundreds of billions of dollars. It's almost hard to get your arms around it. So if we could find a way to use these products more effectively and get paid, at least based in part on the outcome that we've achieved, that's what we mean by no outcome, no income. Another way to think about it is value-based payment, value-based reimbursement, pay for performance. These are some of the synonyms that are in the marketplace. But the punchline is all about, in God we trust, all others bring their outcomes data, and we'd be happy to pay you. We'd even be happy to pay you a premium if you get a great outcome. But if you get a poor outcome, especially if you didn't follow evidence-based practice, you're not going to get paid. And we have good evidence of that today in terms of we're not paying people for readmissions within 30 days. That's a failure to coordinate care. We're not going to pay you certainly if you have a sentinel event. We're not going to pay you if you have a big decubitus ulcer and you get septic from it. We're not going to pay you if you have a central line associated bloodstream infection. We're not going to pay you if your urinary catheter leads to an infection and prolonged hospitalization. And my view of all of that is great. You ought not to get paid. No other industry other than healthcare are you going to get paid if you don't deliver value. So no outcome, no income. Get the money you definitely deserve when you do a good job and deliver value for the money we're spending.
And you feel that we're making sufficient progress toward this end?
If you look at the evidence since 2010, especially nationally, it's very clear that hospitals are improving their performance against all kinds of national benchmarks. And I believe in part because of the stimulus provided by no outcome, no income. We're definitely seeing a decrease in readmissions. We're definitely seeing an improvement in core measures. We're definitely seeing a reduction in hospital-acquired conditions. If you take the state of Michigan as a great example, I mean, they've driven central line-associated bloodstream infections down virtually to zero statewide in a major cooperative funded by AHRQ. But now, with an economic stimulus that, hey, you better get on board with this activity because you ain't going to get paid unless you get a good outcome. So net, we've made a lot of progress in the last 3 years. I think the big question is, would we have done this without an economic stimulus? Tougher question.
You had also predicted a return to capitation as well. Do you see movement in that direction, and how does that fit in with what you just described?
Boy, capitation is a dirty word, isn't it?
It is.
And it brings with it all kinds of emotional baggage, and from Hollywood to Main Street, you know, and your doctor can't do what he or she wants to do for you because of the big bad insurance company. Mm-hmm. All of that, of course, mythology. Let's look at the facts. There is no question that the decade of the 90s, 1990 to 2000, 2002 and 3, managed care through capitation bent the cost curve. That is irrefutable. Of course, people got tired of the gatekeeper model. Doctors got tired of fighting with their perception of fighting with the managed care plan, so capitation sort of went to the wayside. But really, we're coming back towards a bundled payment, pay for performance. These are, if you would, it's sort of capitation in drag, if you would, you know, capitation in a Halloween costume. Because call it something, whatever you like, but here's the issue. The research evidence is pretty convincing. If you pay providers to do a better job, you're going to get a better outcome. Probably at a lower price, probably with fewer mistakes, probably using pharmaceutical agents in a more cost-effective manner. We've got good evidence that this really does work. So is it capitation? Is it bundled payment? Is it something else altogether? I'm not really sure, but I don't like to use the word capitation because of all the baggage.
Right.
Here's a key difference that I do think makes it more palatable today. Capitation was a primary care doctor focused tool, a gatekeeper focused tool. It really didn't engage the subspecialty community. A bundled payment is all about, hey, we've got to work together, subspecialist, hospital, primary care doctor, nursing, pharmacy, and all together, then we have to figure out how to allocate the pieces of that pie. So that's a core difference between 1998 capitation and 2013, 2014 bundled payment.
Good.
So capitation has a reputation for being, in some sense, a perverse incentive not to provide care. You think that the systems that are supplanting it or the new systems take care of that problem?
Capitation certainly had a bad reputation for many reasons. Among them, primary care doctors chafing at their sense that managed care plans were controlling their practice, patients unhappy because they were told by their doctor they couldn't get access to a test. So there is a lot of mythology around the negative aspects of capitation.
I understand that, but I'm asking about the incentive to withhold care.
Right. So there is little to no research evidence that I'm aware of that capitation caused a withholding of care. In fact, once again, if you look at outcomes in the 90s, they were no better or worse than they are today. And then, by the way, we spent a whole lot less money. So I've never been convinced that capitation led to any underuse. You know, the classic description of overuse, appropriate use, and underuse. I've never been convinced by any research evidence that I'm aware of that capitation drove underutilization. There's no population-based measures to support that. So that would argue in my mind that we have a pretty clear pathway toward bundled payment, pay for performance, value-based payment, whichever phrase you like. The punchline, if you pay providers to do a better job, they're going to find a way to do a better job. And the hope is to achieve greater value for the money that we're spending.
Thank you. Now let's turn to personalized medicine. You actually gave a talk a few months ago, and we ran a transcript of that in managed care, in which you talked about the bright future of personalized medicine. But at the same time, you're the founding dean of the School of Population Health. How do these two concepts work together?
Right. So we had a big conference on the Thomas Jefferson University campus. It was the Lennox Black Conference. We award a global award to a nationally prominent scientist every 2 years. So in November of 2012, my conversation about personalized medicine was in the context of the Lennox Black Symposium. And we had some of the top people literally from around the world talking about the progress we've made or lack of progress in personalized medicine. Let's define our terms first, because personalized medicine means a lot of different things. From my reading and the work of people like Eric Topol and others, my sense is personalized medicine goes something like this. I have access to your genetic code, and I know from a buccal smear that I've done, an analysis of your genes, that you're susceptible or not to a whole series of diseases. I understand your mutations, and using that knowledge, I can personalize my therapy for you. Let me give you a concrete example. Personalized medicine might mean that I can tell a priori which antihypertensive is appropriate for you based on your and your alone genetic makeup. So I can have more targeted therapy. I may not need to do screening for prostate cancer, as an example, if I know your genetic makeup and I see what your personal susceptibility is. That would obviate the need for ongoing PSA screening, as an example. For women, I might know your genetic risk for breast cancer, and I would not have to do mass mammography screening leading to all kinds of false positives, extra biopsies, and so on. So on my right hand, we have this miracle of personalized medicine. And in my left hand, we have the current state of affairs of mass screening of populations. So I've called this the paradox of population health. On the one hand, my left hand now, we have every incentive today, where appropriate with high sensitivity screens, to do mammography and pap smears, colonoscopy, screen for high blood pressure, appropriate prostate screening, and all the rest. Very expensive, not targeted. And in the future, I've argued, and smarter people like Eric Topol have argued too, personalized medicine may obviate all of that and enable me to really target your therapy. Whether that will exist in my primary care practice lifetime, I don't know. I hope I'm around to see it. Incredibly exciting, really important breakthroughs. Eric's book, The Creative Destruction of American Medicine, lays all this out in an easy-to-read format. So, summary, population health and personalized medicine, well, it's a paradoxical relationship. Maybe one day we won't have to screen populations. We can really personalize our approach for a whole series of diseases that we don't currently tackle in that manner.
You had mentioned Dr. Topol and the creative destruction of medicine, and he says that this is going to result in a complete change in 5 years in the way that we do medicine. So can you discuss how that will happen and what the converging factors are?
Sure. Eric's book, The Creative Destruction of American Medicine, is an easy to read, fun read. And what Dr. Topol has done, and by the way, you know, what a wonderful pedigree he has, coming from the Cleveland Clinic, now at Scripps. So he's part of a movement not only about personalized medicine, but something they call the quantifiable selfer movement, quantifiable selfers. And these are folks who, with new technology, are regularly measuring their heart rate, their number of hours they're in REM sleep, number of calories they expend every day exercising, how many calories they consume in food. I mean, this is a growing group of folks around the country, quantifiable selfers, who are quantifying what they're all about from a physiologic basis. So Eric's thesis is, well, this group will be engaged in their own care in a way that most average patients are not. So that's going to lead to a creative destruction of the old model and greater patient engagement in their own care. And hence he's using this term from economics, creative destruction, which implies a new level of patient engagement in their own medical care moving forward. That's certainly one piece of it. And the quantifiable selfers are the leaders of this creative destruction. Another aspect of it is the personalized medicine. Eric's contention that if we keep moving the discoveries down the field and make progress in personalized medicine, we won't be having the need for widespread screening, no more pap smears for everybody, no more mammography, no more colonoscopy, only for targeted patients who are at genetic risk that we're able to attribute at the individual patient level. So think of it as these two real powerful forces, the quantifiable selfers, all new technology, telemedicine, engagement, democratization of information, everybody online asking their doctor impossible questions. And then the other movement, personalized medicine. I know everything there is to know about you based on your genes. Here's your mutation. So here's this drug, not that drug, based specifically on your genetic composition. Pretty cool.
It is pretty cool.
So, Dr. Nash, I have a two-part question, related. I think there are probably a number of people watching this video who don't know what population health means. So could you give us a brief description of what population health is? And the second part is, at the School for Population Health here at Thomas Jefferson, you now offer a doctoral level degree.
Right.
Somebody who goes through that program, what exactly would he be learning, and what kind of a job would he get after he got that degree?
Well, I'm very privileged to be the founding dean of what remains the only school of population health in the United States at this moment. It is true that there are departments of population health in various medical schools, Hofstra, NYU, and elsewhere. There are institutes of population health, University of Wisconsin and Madison, where one of our founders, David Kindig, the founder of the movement, is still working. But here at Jefferson, we are incredibly lucky to have an entire school exclusively devoted to population health. Now, what does that mean? So the way we interpret population health, I'm going to give you a two-part answer. The literature says population health is based on three things. One is the recognition that there are outcomes of medical care that are unevenly distributed in the population: morbidity, mortality, and quality of life. That's one tier. Second tier of population health says, well, those outcomes are distributed based largely on the social determinants of health: where you live, your socioeconomic status, your level of education, where there's poverty, where there's crime, where there's pollution. All of those social determinants have a big impact on your quality of life. And the third component of population health says, guess what? Laws and policies like the Affordable Care Act are also in the mix. So here's the punchline. 85% of a population's well-being, its quality of life, is due to factors other than medical care. 85%. Another way to look at this is what we do at Jefferson and at all of our sister organizations out there and all providers, doctors, nurses, pharmacists, hospitals large and small, we account collectively for 15% of a society's well-being and quality of life. The other 85% has all to do with disparity in income, crime, poverty level, geography. Zip code in our country is destiny with regard to health care. Air pollution, access to fresh fruits and vegetables. All of these messy, complex social determinants, they're the driver of 85% of how a society measures its quality of life. Just parenthetically, before we get to your second question, if you look at the United States, according to the most recent data, July 2013, reports from the National Research Council, January 2013, another report from the NRC called Shorter Lives, Poorer Health. Irrefutable source says the United States of America, despite all of our spending on health care, we're number 17 in the world with regard to quality of life, right behind Slovenia. So that's where we've ended up for the incredible investment of 18% of our GDP. So summary, population health, it's all about what goes on outside the four walls of the hospital and the four walls of the doctor office. All that messy social determinants of health and the policies that drive it. Oh, and by the way, of course, choosing your parents wisely does have a role in all of this. That's about 15% of the story. Let me answer your second question about our work at the School of Population Health and our doctoral program. So as I hope some of our viewers know, in my role with P&T Magazine, our School of Population Health, we have 4 master's degrees. A master's degree in public health, fully accredited at night for working adults, and then, John, 3 unique online master's degree programs, one in healthcare quality and safety, one in health policy, and one in health economics and outcomes research, getting to the questions we were talking about earlier about cost effectiveness, NICE, and the like. So 3 online degrees, 1 in-person at night program. On top of those 4 degrees, we have our doctoral program in population health science. We expect that our graduates of this program, and by the way, there aren't any graduates yet because we've only been open for 4 years, we expect that doctoral level graduates of our program in population health will be expert in one of those areas, in health policy, in quality and safety, or in health economics and outcomes research. So they can't be expert in all of those, but we do expect at the doctoral level they will have done original research, defended their thesis and their publications in one of those 4 principal areas. And I expect that our doctorally prepared graduates will be leaders in academia, leaders in the policy community, joining think tanks in Washington, participating in state and national conversations about health policy. Half of our current student body already have a master's degree in something. And healthcare is a highly credentialed field, of course, so it's no surprise since most of our students come from the healthcare world across the whole spectrum. About half of them already have a master's degree, so they're working with us to achieve a higher level of understanding and more details, to get promoted, to make a greater contribution, to achieve a leadership position, many different reasons. But in summary, our doctorally prepared students, we hope to have a few this coming May, are probably going to be leaders in academia, leaders in industry, and leaders in the policy community.
You have talked about Humana, Cigna, and insurance companies harnessing big data and organizing it at the individual patient level. So how do you see that playing out?
Well, big data certainly is getting a lot of attention, and it's sort of like population health. What is this all about? So why don't I give you my definition of big data, and then let's tackle how the provider and payer community both are using big data. Well, there's a recent Harvard Business Review cover story about big data. There's a brand new journal out there on big data in healthcare, pretty incredible.
Wow.
So my understanding of big data goes something like this. If you really want to understand the health of a population, let's go back to those social determinants and connect the dots. So if obesity and smoking and socioeconomic status and income disparity and all of those social determinants are important, well, that's a lot of data. And you're going to have to find that in all different sources. Then we're going to connect all of that to actual clinical outcome, utilization of pharmaceuticals, length of stay, appropriate testing. So we're going to bring together the clinical stream of data and all this community stream of data. When you put those together, it's synergistic, it's exponential. That, to me, that's big data. Mm-hmm. So I can only really understand my population of patients with diabetes if I understand where they live, do they smoke, what schools have they gone to, what does their tax return look like, and so that's big data. And maybe a subsidiary of big data would be what the exchanges are trying to do. Check your tax status, your previous employment, all of that, then determine whether you're eligible for which level of exchange. I mean, that's a big data question too. But that's a really important part of what I believe big data is all about. Mm-hmm. Now, part 2. Well, I think the payers are very interested in harnessing big data because they want to see, basically, they want to answer the question, how do I achieve value in the marketplace? Where will my investment yield the greatest return? Is it on pediatric asthma hospitalization in these 5 zip codes? Is it on flu vaccination in these 10 zip codes? Is it on open heart surgery in these 3 zip codes? We are really just at the very beginning of this national movement to assess the impact of big data. Then imagine if I'm a Aetna, Cigna, Humana, I could drive patients based on outcome to certain providers. We're already doing that to some extent, right? Centers of excellence and so on. But imagine if I'm a Humana beneficiary in South Florida, Humana's largest market. I want to make sure that I'm sending my Humana beneficiary to the Florida hospital that's going to give them the best darn outcome for the money that I'm spending. And I may only be able to understand that outcome if I had big data to support it. So I believe all the for-profit managed care plans, all the for-profit insurance companies be very interested in the impact of big data.
So big data's big.
Big data is big and going to get bigger.
Dr. Nash, when we had our last interview in 2010, you talked about the use of a registry to organize data and how useful this would be. Now, I know that there are registries in use all over the place.
Yes.
For clinical conditions. What exactly is your vision of this larger registry? Is this like everything about every person and in a three-dimensional or grid and then we kind of slice and dice it this way and that way? What exactly is your vision there?
My view of what a registry is today and where I think we're going, oh, this is a very exciting area. In my primary care practice, as an example, I hope I live to see the day when I could come in the morning, have my panel of patients, on my office laptop, call up my registry function, and there will be Dr. Nash's performance on a population basis, comparing me to my local peers, regional, and even a national peer group. Here's what I mean. Imagine if I could have on the screen, using registry-like software, and there's a bunch of companies doing this already, as you alluded to, Synaptic, Phitel, among others. I want to be able to say, hey, how am I doing in the care of my patients with congestive heart failure? Let me see their functional status. Let me see their readmission rate. Let me see their average weight loss under my diuretic therapy and their blood pressure, or their ejection fraction. And there would be my population with all of that data displayed. And then a comparison population holding severity of illness constant, so I could compare my performance at an outcomes basis with other doctors, other provider organizations. So the registry function will enable me, if you would, to practice population-based medicine. It will enable me across all my patients in given clinical conditions to understand how I'm doing relative to a benchmark group. And I could think of lots more measures I'd be interested in. Readmission rate we've already mentioned. How about generic prescribing? How does that connect to my outcome? And gee, my partner seems to have a higher generic prescribing rate, and look at his lower length of stay, patient satisfaction scores, lower readmission rate. Maybe there's something I can learn through this registry function that my partner 3 doors down in the same practice is doing. Now let's take my practice and compare it to some other academic medical center, some other community hospital, see how they're doing with a comparable group of patients. Maybe we could really all learn together. That's the vision that I have from a registry function. Challenges are great. We're not going to get a registry out of just a plain vanilla electronic medical record. That's not going to happen. We need to graft on top of the EMR a registry software engine that's going to pull data from all kinds of sources, not just the inpatient arena. We're going to need to link outpatient and inpatient at a minimum to give me a robust registry function. The good news is these products are currently available on the marketplace. Lots more are coming, and ultimately we're going to get paid based, at least in part, on our population-based measures. So I'm very excited about registry opportunities. I'm a little wary about how I'm going to do and how I'm going to measure up relative to my peers. I hope I'll be competitive in the future, but you know, again, no outcome, no income. So a registry is a tool that will help me to achieve a better outcome, and I darn well better get paid more for achieving that good outcome.
It is true, isn't it, that physicians do respond positively when they are presented with actual data on their performance, right?
There is no question, based now on 25 years of research from Brent James' original 1975 experiment in Salt Lake City all the way through the Institute for Healthcare Improvement, the work from our school and hundreds of others, and PCORI, CMMI. The punchline is you give providers good information in a timely way from a reliable source that's non-punitive about how they can improve what they do, and then you give them the skills to improve, you better get out of their way because they're going to stampede to improve. But let's go through those steps. First, you've got to close that feedback loop in a timely way. We rarely do that. You got to give me good information based on my patients, because you know my patients are way sicker than yours. It's got to be delivered by somebody I trust. Can't be just Uncle Sam sending me an email. It's got to be face-to-face. I want to understand how I could do a better job. So you got to do all that. Then you've got to give me tools, quality improvement skills, a master's degree in healthcare quality and safety, an ability to analyze my data. And you got to protect my time to do that. Once you give me the good information and you give me the skill set to improve, then you economically incent me to improve, I'm going to knock your socks off about how fast I can do a better job. That is the key.
And in the primary care area, this opens the door to the use of physician extenders, doesn't it?
You bet. So I'm going to need a team to do all this work that we just described, right? I might need a physician's assistant, a doctor in nursing practice, a diabetes nurse educator, a care navigator, an epidemiologist, a graduate of the School of Population Health who's going to help me with these tools. Sure, this is a team sport to improve. All improvement is teamwork.
Now, my internist, general internist, is a solo practitioner. He's not going to be a solo practitioner in 10 years, is he?
The future of the individual 1- and 2-person practice, I think there's not much future left in our world for the private practice, 1Z, 2Z office, struggling with an electronic medical record, trying to achieve meaningful use, under-resourced, not part of a registry, unable to benchmark their performance. I think, and most of the experts in this area would agree, that we're going to see the rapid demise of the 1Z, 2Z private practice primary care doctor. First of all, there's not enough of them. There are not enough in the pipeline either, and the whole reimbursement model is going to be around infrastructure and improvement, not individual doctors doing the same thing they've been accustomed to doing, principally since the Second World War.
Do you think these new efforts with the patient registries and big data will help primary care providers improve their relationships with patients in the process?
Speaking as a primary care doctor, I'm very excited about the future of patient engagement. I'm a little wary of it, but generally I'm pretty excited. I think those quantifiable selfers, they're going to teach us a lot. They might be a difficult group to deal with at the outset, but we're going to learn a lot from them. I'm always, give me a patient who's engaged in her own care any day. Give me a patient, if they're engaged, they're going to be compliant with their medication. They're going to work with me to achieve a mutual goal. But you're going to have to pay me to practice in this new way and to ask patients what's their desired health outcome, to participate in a shared decision-making model. It's way easier just to get paid to do more. And so if we don't change the payment system, we're never going to change the core of what primary care is about. But at the end of the day, I'm pretty excited. I hope I'll live to see total patient engagement with me. It's going to be scary, but fun, and I'm looking forward to it. I'm definitely excited about where primary care is going in the future.
Well, thank you, Dr. Nash. Our time is up, and this has been a very enlightening and enjoyable interview.
Great. Well, thank you. All the best.
See you next time.